Fifth anniversary celebrations for today. I am Dr. Jalgam Kavya Rao, Clinical Head and Fertility Specialist, and I am excited to be your host for the evening. So, coming to the OSS fertility, I would just want to brief about this. We are very proud to share that in last 12 years of our journey, we have built one of the most respected institutions in the field of reproductive medicine in India and have developed over 35,000 couples achieve their dream of parenthood. At OSS, we pride ourselves on the impeccable standards in maintaining our IVF lab and advanced lab. The lab is very crucial for the treatments offered at our center, and we ensure that the highest level of quality is maintained here. Through advanced treatments like PGS and vitrification, micro-TB success rates can be improved. At OSS, we treat many couples with history of failed IVF and successfully offer better pregnancy rates. Well-trained, experienced team with state-of-art facilities has helped OSS successfully offer advanced treatments under one roof. So the objective of conducting this conclave is to empower clinicians from across the city by the way we interact, by the interactive sessions on advanced fertility treatments. At the end, we expect the participants to get empowered with the knowledge and recent updates on fertility treatment aspects so that they can start treating more infertile couples. So now I request Dr. K. Purushottam, Sir, President, Warangal OG Society. Sir, please, we welcome you on the dais. Dr. B. Sandhya Rani, Madam, couldn't join, but Madam will be joining in shortly. Dr. Kasturi Prabila, Madam. Madam, please, we request you. Dr. Shakamuri Sandhya Rani, Madam. H. Sandhya Rani, Madam. Madam, please. Yeah. Dr. Manjula, Madam. Madam. Dr. K. Radhika, Madam. Dr. Sri Lakshmi, Madam. Dr. Lakshmi Reddy, Madam. Dr. Durga, Madam. And Dr. Krishna Chaitanya, Sir. Sir, we request you to please join for the light lampening.
I warmly welcome all the esteemed Vaxian members for today this EME of Oasis and Warangal Obstetric and Gynec Society. Now the lamp lightening program, that is Jyoti Prajwalana, by the invitees onto the dais.
विनाशाय दीपज्योतिर्नमोस्तुते दीपज्योतिर्नमोस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः ओहरतु मे पापं सन्ध्यादीपनमो ब्रह्मरूपस्थं ज्योतिषां प्रभुरव्ययः भूदेव ब्रह्मरूपस्थं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्राश्च पतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति तदिन्द्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, everyone. With all your blessings, we are going to start our academic session for today.
See you. Hello. Now I request Mr. Sudhakar sir, CEO of the Oasis Fertility Center, to brief about the Oasis centers at Hyderabad and Warangal. Sir, please kindly come and
Thank you so much, sir. Definitely, I think I'll start with the briefing what happened in Warangal today. Thank you so much. Yeah. And good evening, all. I'm not going to stand between your scientific session and the introduction of Oasis. So we are very glad today. In fact, very special day for us because we complete 5 years of Oasis. Our center's 5th anniversary today in Warangal. In fact, back in the day, we actually celebrated the 5th anniversary. The joy was actually shared by our patients. A lot of parents with the kids had actually come. Dinesh, if you could kindly play that video. So this happened today in the afternoon in the same hall as we are sitting here. In fact, those happy smiles are was just possible because of all your support. Because all these patients whom Dr. Kavya has treated here have come from a lot of peripheries areas of Warangal as well as Warangal. I think that all the credit goes to you all. We request you the same support as we got in last 5 years. In fact, right. So this was about Warangal. In fact, I think today, as we celebrate 5 years, I would also like to tell you that we have actually completed about 1200 IVF in Warangal with 65% of success rate. Thanks to you again. Well, that was about Warangal. I'll quickly talk about our Oasis journey. In fact, we also recently celebrated our 13th anniversary. We have just got into teens. We are 13 now, going on to 14. We started way back in 2009, in fact, by none other than Dr. Durga Ji Rao, who is among us. She's one of the co-founders, along with Mr. Kiran. He's our another co-founder and managing director. Core medical team, again, Dr. Durga Ji Rao and also Dr. Krishna Chaitanya, who is going to speak today. And I think the journey began with a humble single center in Banjara Hills way back in 2009. And today, if you look back 13 years, we have created centers of excellence all across the country. Today, we are operating 28 centers. And our aim is to look at about 50 centers in the next couple of years' time. Right? This is very recent as about a year, 1 week back. Happy to share that we have been nominated as #1 clinic in not only in South India, but also in India. In fact, we are #1 in Hyderabad. And this has been accorded by the Times of India group. Yeah. Sure. I think series of awards. This is probably our all eclots which has been given to us is fertility over last 1 year's time. Well, I think one of our nerve center is fundamentally our patient centricity. We are extremely towards our patients, and I think that's one of our secret of success in terms of what we have built today. Right? For us, I think the most important person on the floor is the patient, and we have NPS score of almost about 92%, which I'm glad to share here. Right? Well, and we are not in a rat race to become a number one or a number two here. What we would like to build here is the most respected fertility enterprise in the country today. I think for us, it's important that we focus on our values, and that's our ethos. And for Dr. Durga ma'am and all the people down the line, I think it's the most important factor is to thrive hard to give a biological child to every couple who is visiting our center. Right? Speaking about core values, compassion, competence, customization, confidentiality, and being very careful with our treatments in terms of not mixing up the gametes in the lab is something which these are our core values. And for us, more than commerce, I think credibility is what we look forward for. This slide tells all about Oasis Fertility. This is what we do on an annual basis: 15,000 IVF cycles, 20,000 IUI cycles. So far, we have treated more than 65,000 happy families, and we have collective experience of more than 300 plus when we talk about all the clinical experience which we have put on board today. And our success rates are well above the benchmark comparing to the global standards. And what we started in 2009 with about 10 or 12 employees, today I'm glad to share that we are a 600 plus organization. Well, for us, I think quality is very close to our heart. We have been adhering to highest standard qualities. We are a NABH certified organization. We are also a QI accredited. We are a member of ASRM, FOXY, as well as we are governed by ICMR, right? And I'm sure everybody is aware that very recently the new AIT law has been passed, and we are fully complying with that. Right now we are going through the all inspection stage. Out of our 28 clinics, 26 are level 2 and 2 are level 1 clinics. We have also applied for ART bank as well as for surrogacy clinic. Well, talking about our state-of-art labs, all our IVF labs have got class 10,000 environment, and our consumables are tested for toxicity through the MEA way. And all our labs have got centralized AHU with HEPA filters, and in all our labs, we have witnessing system for 0 errors. Wide spectrum, it's okay. Wide spectrum of advanced services. I'm sure everybody is aware of it, but I would like to focus on a couple of things. PGT is something which we do in highest numbers in South India. Also, when it comes to micro TC, I think that's what we do under our Andro Life Clinic, which is specialized male fertility clinics. We have operated more than 200 patients for micro TC so far, which is highest when it comes to the number of micro TC procedures which happen in the country today, right? Our success rate, I'm sure Dr. Krishna, Durga ma'am, everybody will speak about it more in the session. One thing which I would like to kind of share, this is how we differentiate from other clinics, is fundamentally we are a daycare clinic. We don't do OBG or we don't do gynecology at all. When the patient conceives, we make sure that the patient goes back to the respective gynecologist, because we are just a daycare center and we just focus on fertility. Most of them feel that we are expensive, but we are not. I think what we need to understand in fertility treatment is time is essence. And when we treat the patient, that's what we call as value for money, right? This is our information system, one of the smartest information system which we have in the country today. We call it as ARTIS. This particular system actually tracks the journey of the patient right from the first phone call before even the patient enters the clinic till the patient actually gives birth to the child. So the entire journey of the patient is actually tracked in ARTIS. And glad to share that we have got more than 65,000 patient database, which will be enabling us and helping us to start our artificial intelligence journey in Oasis fertility. Well, you'll agree with me that today fertility is just not about female perspective, but also 50% is contributed by males. That's the reason why we have started Andro Life, which is our dedicated male fertility clinic. As you are aware, or will agree with me that male is always in denial and would be happy to actually speak to a male doctor. That's the reason why every clinic we run a Andro Life clinic. I'm sure Dr. Krishna will be speaking more about it. We believe in giving back to the society. That's where we run this particular program called Amulya. Amulya is a CSR activity wherein we are happy to help any one of your poor patients. We would actually do a free IVF to your patients. In case if you have any deserving patient, kindly send it to Dr. Kavya. We'll be more than happy for this, right? Well, this is my last slide, focusing on academics. Again, academics is something which is very, very close to Durga ma'am's, Dr. Krishna's heart. We run FRM program, which is 1 year program. We also have 2 seats every year through DNB, and we run various other weekend courses, short-term as well as long-term courses. If anybody requires information about it, kindly reach out to us. We'll be more than happy to give you this information. With this, thank you so much, Dr. Kavya. Requesting you to take it forward.
Thank you, Sudhakar sir. That's so brief about Oasis. Now I request Dr. K. Radhika madam to introduce Dr. Durga madam for the next session.
Good evening, everybody. It's my privilege to introduce Dr. Durga Madam. We have known her from the inception of Oasis in Warangal, and she's the co-founder and the medical director of this Oasis Hospital. She's a specialist in reproductive medicine and minimally invasive surgery with almost 26 years of experience, and she's the leading voice in infertility industry and a pioneer in the research practice and in vitro fertilization, and she's done her practice in Canada and UK, and she's very responsible for bringing the most advanced ART treatments with her experience, competence, personalized approach, along with extensive knowledge. We welcome you, madam.
I think that this time the endeavor has been to sort of leave the more exciting topics of management of fertility to Dr. Kavya and Dr. Krishna. And I just wanted to take a step back and speak about what, as a gynecologist, we should be doing whenever we see, women who are not specially coming to us for fertility, but who, as a responsible gynecologist, is our duty to ensure that we are preventing it. So what we are actually trying to do, and what I want to address today, is can we look at infertility or subfertility as a part of preventive medicine? Why are we even looking about this, and why did we think about this? When we were starting, this is about 20 odd years ago, the statistics that were taught to us is fertility incidence is approximately 1 in 7 couples. What are we talking about now? It's actually 1 in 5 couples. So when I looked at the database in terms of what India is actually struggling with when we're talking about fertility, and what is the whole concept and what is the quantum of infertility in our country, what we have found is that 4.5 out of 100 currently married women within the age group of 15 to 49 actually suffer from fertility. And when we're looking at the whole quantum, it is approximately 11 to 15. the age group of 20 to 49. Now, what does these figures actually mean to us? As a fertility specialist, we know that of this 10 to 15 million women who are suffering from fertility, only approximately 1% actually end up coming to specialist centers, which means that there's so much of a need which actually hasn't reached down to the grassroots. The accessibility of infertility treatments is not for everybody, which is why the whole concept of how do we prevent it and how do we bring these figures down actually comes to mind. And looking at this is the graph of the age of a woman in terms of conception. When we are looking at 15, 16, which is the, or rather 92, 93, which is the blue line, you found that the age-specific fertility rate was much higher. You compare it to the black line, which is talking about the same rate in 15, 16, and see how it is shifting. Not only is it shifting, it is also coming down. In fact, in most society nowadays, there's been a bit of a panic in terms of the fact that some countries, their fertility rate is coming down so much, it is actually going to be a concern in terms of the population. And even in India, though we are talking about our population being 2 billion, we are concerned now that because of the cause of infertility, it's not just about infertility. In fact, some couples are choosing not to conceive also. And with the compounded problem of infertility, the rate at which the population is growing is actually plateauing. And that as a country is very concerning. Now, when we are talking about fertility, obviously, once they come to the concept of being infertile, there are a lot of concerns that we have to deal with when we're talking about this couple. Emotional, economical, and this is the reason why I said only 1% actually access medical care. Because right now, fertility treatments are still expensive. Though we have been in the field for the last 45 years, we haven't managed to bridge the gap. The consumables are expensive, the drugs are expensive, the skill is expensive. Whatever said and done, we are not able to bring down the cost of fertility treatments, and which is prohibitive for most of the people in India. We are also looking at the fact that there are medical impacts about these women who are infertile. So, are we looking at treatment now? What I want to do is advance further and look at prevention. So, what is it as a gynecologist should be our goal is see whether they don't even come towards a fertility clinic and give them the maximum support possible to conceive naturally. So, this is the concept that we wanted to initiate. Puberty to 30. Obviously, once she crosses 30, we might have to come into the picture, but while they are still in your domain from puberty to 30, as a gynecologist, we should see that they don't cross over and become infertile. So every woman that comes to us, as a gynecologist, the first question that we have to ask ourselves is, let it be an adolescent also, is this one particular child or a woman likely to have infertility in the future? We are not talking about them coming with the concept of fertility to you. We are talking about them coming to you for other reasons. But as a preventive measure, as a gynecologist, the first question that we have to ask ourselves is she likely to have infertility in the future? Now, when we were really looking into this concept of making infertility preventive, there are quite a few data out there. In fact, what they are asking is this question: if a woman is infertile, is it also compromising her future health? And this data, which is looking at the huge numbers that we have, they felt that a woman, when she's infertile, the relative risk of all cause of mortality is 1.19, which is significant. Infertility may not kill her, but the associated abnormalities, metabolic and other reasons that have made her infertile can also increase her mortality. So we are moving away from fertility. I'm not talking about fertility at all. I'm talking about how a woman, when she becomes infertile, and all the issues that she has to deal with. We all know the common causes of infertility. 30% is men. you have at least 30% with tubal damage, and you have ovulatory failure, and obviously another 30% of unexplained. Now, when we are looking at those causes, those are the broad-based causes. But when we are talking about preventive, what is it that we can do? Lifestyle. And I think this concept is not just for gynecologists, it's not just for fertility specialists, it is there for cardiologists, it is there for even the oncologists, to name a few. Obesity, smoking, drinking, lack of exercise, lack of proper diet, lack of proper sleep. Even something as menial and as small as sleep can actually interfere with a woman's reproductive function. What about extremes of weight? We know that women, when they're obese, menopause is less as compared to a normal weight woman. There's a shorter period of her menstrual cycle, higher risk of miscarriages, maternal death, hypertension, preeclampsia, gestational diabetes, preterm delivery. You know, the list is endless. And we all know this. We're not, again, to emphasize, we're not talking about fertility. We're talking about, as a woman, if she's obese, look at all the issues that she has to deal with, in addition to fertility. Stress, mood swings. They have inappropriate dietary patterns, leading to malnutrition, and in the other extreme, obesity. There's a higher risk of developing depression, anxiety, behavioral disorders. And because of all of this stress, your ACTH levels are actually very high. And they impact cortisol, and that again impacts your whole HPO axis. Now, like I said, even something as small as sleep, what does it do? When your circadian rhythm is disturbed, like how you have nowadays, you have your IT sector, most of them work in odd hours. So their whole circadian rhythm is actually changed. And what does that cause? Obesity, cardiovascular disorders, sleep deprivation, altered dietary habits, alcohol, smoking, caffeine, all of this, in addition to the abnormalities that they have in terms of their HPO axis. And what are the mechanisms? You will be surprised to know that there are even genetic mutations that happen because of altered circadian rhythms. And most of the hormones that are involved, which is your GnRH, your gonadotropins, and your sex steroids, all of these, which actually help in the rhythmicity of a reproductive function, are completely derailed. And therefore, your prolactin, your thyroid, your glucocorticoids, melatonin, all the levels and the secretion and the whole metabolism is actually changed. And as we know, this is all connected, leading to one of the problems, which is infertility. And we are not just talking about our lifestyles and the issues that we have with it, but we are also talking about the age that we are living in. Why have I shown you those diagrams and those graphs of actually infertility rising, as well as the impact of live birth coming down? It is also because of the times that we are living in, which involves pollution, it involves all the environmental toxins and occupational hazards. You know, we never go out without a phone. We really don't know how much radiation that we are actually carrying. What about the young people? What about the kind of water that we are consuming? Unfortunately, even here we are having a bottle of water, which is plastic. Plastic has dioxins. Dioxins in turn cause endometriosis. So we are not just talking about how we are destroying our planet, we are also talking about how our lifestyle is destroying our own systems. Here again, why do we see a rise in male infertility? Dr. Krishna will be speaking about this in detail, but what we are really looking at is this: endocrine disrupting chemicals. This is what is actually causing the whole rhythm of your HPO axis to go array. And what actually increases your endocrine disrupting chemicals? It is all the pesticides, it is all the organophosphorus things, we are talking about metal, so many issues, the pollution. In fact, in Delhi, a few days, the schools were shut because the smog and the pollution was so much in the city that it was going to be dangerous for the kids to actually move out of the house and go to school. When we are talking about that kind of level of pollution in the atmosphere, what is it going to be doing to our molecular systems? Now, that we are talking about is all about the lifestyle that we have to advise them. But specifically, if I'm talking about gynecologist and our duty, the things that we have to look at, even if a woman is not coming for fertility, like I said, is she likely to have low reserve? Is she going to need surgery? If she's going to need surgery, but she hasn't completed her family, what are the precautions that we should be taking? Suppose a woman comes, she's for some other reason, she's not used contraceptive, but she still hasn't conceived with her husband having been in a sexual position, then we have to understand that there is a problem there. Because there are a lot of couples who still coexist in the relationship but don't use any contraception. And they don't seem to think that there's a problem. But as a gynecologist, I think we need to identify this group of people as well. Once a woman crosses 32, 33 is also something that we have to be alerted about and rather counsel them about what their chances are in terms of fertility. Low reserve. Again, like the incidence of infertility, the incidence of low reserve is also increasing. In fact, 1/3 of the couples who are walking into our clinic are ending up with low reserve. This used to be 20% before, but now we are close to approximately 1/3 of our women having low reserve. Now, when we are talking about the surgical principles, which is what I was speaking about, it's very important that whenever we are doing any kind of surgery in a reproductive age woman or even in an adolescent for any reason, we have to look at how we are going to reduce adhesions. The pelvis that you're going to leave at the end of the surgery, when it has to be reopened again for any other reason, should never look as if there's had a surgery. What are the implications? We have to reduce adhesions. We have to try and see whether the starch-containing gloves of us that we are using, the dry towels, the sponge, and all the things that we are actually trying to do is actually going to increase your adhesions or not. Diligent homeostasis, because if you're leaving blood in the cavity, there's very likely that it is going to cause adhesions. Limit the use of diathermy. Diathermy causes more adhesions. Look at the suture material that you're using. So there's so much of attention that we have to pay to this group of women, even if they're doing surgery for some other reasons. Try and choose a very fine and a non-reactive suture material. Use frequent irrigation and aspiration. Don't dry the tissues out. Reduce the pneumoperitoneum when we are doing laparoscopy, and also take measures to reduce the risk of infection. Now, even something as simple as a hysteroscopic myomectomy, if it's done in a reproductive age woman, we have to be known that this is one of the conditions that actually increases intrauterine adhesions. I'm just picking the major factors here. Obviously, there are lots of hysteroscopic interventions that we do, but which causes a likelihood of the woman reaching up to us in terms of infertility is what I wanted to discuss. So, of the lot, in terms of hysteroscopic interventions, hysteroscopic myomectomy is the one that increases your risk of intrauterine adhesions. In fact, it is less than 10% of them that might have intractable adhesions. So what do we have to do there to avoid it? Surgical technique, avoid the use of excessive diathermy, okay, and try and preserve the endometrium as much as possible. Not only that, when you are looking at multiple fibroids, see whether you need to do it in different stages, because if you're removing fibroid from opposing surfaces and after the whole diluent and all the fluid is removed, then the opposing surfaces come together and then it will be difficult for us to reduce your adhesions. Endometriosis. In fact, if you were to ask a gynecologist, what are the things that are more likely for us to see whether we can prevent infertility? There are three things: endometriosis, PCO, low reserve. If I were to bring up the three most important factors that we have to take care of, it is this. Endometriosis, even in an adolescent and young woman who comes to you with dysmenorrhea or dyspareunia, the first thing is to rule out endometriosis. Because there are so many people out there who have not been correctly diagnosed. They get diagnosed only once they have tried fertility, they have failed, and then they come to us, and then by the time they come to us, they have shifted from endometriosis to low reserve. So when we are first seeing them and they come to us with these symptoms, it's very important for us to take the trouble of diagnosing them. Why is it important to diagnose them? Because then you are in a position to try and prevent the progression of the disease. Our most important object here is to prevent the progression. Up to 10 to 15% of women in India tend to have endometriosis. And in these 10 to 15% of women who have endometriosis, imagine 30 to 50% of them will end up with infertility. They keep coming back to us with the same symptoms. We keep seeing, hemorrhagic cysts. We keep seeing endometriomas. We keep doing surgery, and they end up with low reserve. So any woman who has a recurrence of endometriomas, who has large cysts, who has bilateral cysts, and there's a quick recurrence, I think this is an alert for us to understand that this woman is likely going to end up infertile, and we have to give them the right kind of advice. What about fibroids? Fibroids, again. This is a mechanical reason for infertility. So if you're seeing a young woman with fibroids, obviously it is going to grow as she grows. And then it might be coming in a situation wherein she might need major surgery before she goes for infertility management. So what can we do to prevent the progression of the fibroids is what we have to answer. And these two extremes of irregular periods, PCO and premature ovarian insufficiency, the two extremes of the same spectrum. Now, when a woman comes with irregular periods, obviously, I'm not going to be talking a lot about PCO because we all know that. We have to advise them about lifestyle management, weight management, and everything, put them on metformin, help them with in terms of their psychological aspect, in terms of the depression, look at their hyperandrogenemia and all of that. Why do we have to do that? Because we have to stop the progression. We are not curing the disease here. We cannot cure it. Endometriosis cannot be cured unless you're removing the ovaries. But what we have to do is stem the progression of the disease. If you're looking at PCO, you have to do that. If you're looking at premature ovarian insufficiency, then there are other measures as gynecologists that we have to advise them. So in these two conditions, minimize disease progression, preserve fertility. In fact, if you can, restore fertility. What do I mean by restoring fertility? If you're doing a laparoscopy and you're seeing endometriosis, you're looking at adhesions, you're doing hysteroscopy, you're looking at adhesions, obviously the fertility is compromised. So what we are trying to do with our interventions is to see whether we can restore their fertility. Thyroid. So often women come to us, but we are not detecting whether she's hypothyroid or not. And looking at hypothyroidism, it has its involvement in ovulation disorder, irregular menstruation, infertility, and also risk of miscarriage, as well as neonatal morbidity. What about prolactin? One blood test. And if we don't do it, there are so many implications of a hyperprolactinemia, which can also affect her fertility. Pelvic inflammatory disease. Now, the whole problem with this, like tuberculosis, is the diagnosis. Just because a woman comes with lower abdominal pain, you can't say that every woman who comes with a lower abdominal pain is ending up with PID. But I think that is where our clinical acumen has to come into the picture to see whether this woman is at risk of PID. And if it's not treated at the right time, the sequelae of PID is obviously going to make her infertile. What about tuberculosis? Thankfully, at least in our part of the world, at least when we're talking about our two states, tuberculosis is not as prevalent as it is in the north. But I think the symptoms still have to alert us towards a possibility of tuberculosis, because if we do not treat her at the right time, the sequelae of tuberculosis are such that even fertility treatments can be difficult for them. Asherman syndrome. If you ask me, most of the cases of Asherman syndromes are iatrogenic. What do I mean by that? Curettage in a woman who has miscarried. So for us, she miscarried, she's got clots in there, or we are looking at surgical management, get your curette out, take out all the clots. What we don't realize is a pregnant uterus, if you're going to do a very harsh curettage, she is going to end up with destroyed basal lamina of her endometrium and end up with Asherman syndrome. Removal of even retained placenta. Delivery done, placenta remains, and we do a very a thorough curettage because we don't want to leave any bits and for her to come back with bleeding. What we are ending up and giving her is a very thin endometrium, which is not suitable for implantation. And frankly, we still don't have treatment for that. So she came to us with a problem. but we are giving her a more sustained problem, which is frankly not treatable. Obviously, untreated tuberculosis. So these are the conditions that we as gynecologists have to be very careful. And this is the reason why medical management of miscarriage should be our first option before we even look at surgical management. And if we are looking at surgical management, see whether you could do it under ultrasound control, do it under hysteroscopic control to try and minimize the use of a curette. Any sharp object removing or curating a pregnant uterus, if you notice that the first two indications are in pregnant uteruses, and they are the ones which end up having the most problem. Now, when we were really looking at the concept of prevention of infertility and looked at some of the data that came across, this was a paper that I had come across which said that I wish I had known sooner. And in fact, most of the women who have crossed 33 or 35, when they come to us and we tell them about the problems that they have, the most important thing that they go away with, why didn't I do something about this sooner? It is not about her not doing it sooner. It is about the medical system and the informational system that has failed her in giving her the awareness and the knowledge about the fact that infertility is actually timed. And if we don't do the right things at the right time, we end up with issues. So the most common thing that people have heard is that their patients come back and say, I wish I heard sooner that there was a problem and I needed to look at fertility at a younger age. And what this paper actually looked at is they seem to find that these three groups of women actually seem to have the worst prognosis. Women with lower incomes, women with less education, women from the racial and the ethnic minorities. So in these group of women, what they actually found was infertility was highest. Why was it highest? Obviously, the information did not reach them. They weren't being made aware of the problems that are associated with this. So what should be our approach? We speak, even in schools, you have sex education. They are spoken about safe sex. They are given a lot of information about contraception. So initially, all our information and everything is concentrated towards an adolescent saying, don't get pregnant. These are the ways you should not get pregnant. Very good. We need that information. But on the other hand, they should also be told as to what are the reasons and what are the conditions that can actually cause fertility and what is the right time for them to conceive. Our focus is gone so much on this, and rightly so. When we are talking about 2 billion population, we have to look at population control. But things have gone now in a reverse direction. And so we have to be talking about fertility and the issues that we have. That was the general approach. We also need to have a targeted approach. What do I mean by targeted approach? The women with the known infertility risk factors that we spoke about till now: endometriosis, PCO, premature ovarian insufficiency, thyroid, hyperprolactinemia, the issues with stress, the issues with sleep, the issues with your lifestyle. All of this are what we have to be discussing with them when they come and see us. So if I were to summarize the fertility risk factors: demography, age, if she's more than 32 or 33, reproductive endometriosis, menstrual cycle irregularities, pelvic inflammatory disease, sexual menstrual pain, pelvic surgeries, intake of 14 units of alcohol per week, 7 or more units of caffeine per day, illegal drug use, smoking, stress, weight, and unprotected intercourse with multiple partners, because that can lead into STD. So there are so many things that we can do when a woman comes to us. So what should we do? Identify the woman. Counsel, educate, make her aware about the issues that she's dealing with and how it's going to implicate future fertility for her. I've spoken about prevention, right? I've spoken about all the things that can cause fertility and what we can do to reduce it. But what is the advice that you're giving them other than making them aware? You also have to tell them that a woman who's coming with endometriosis, even if she's 24, she's got bilateral disease, recurrence is high, she's already had surgery. What are you going to be doing? Yes, you will suppress the disease, you will give her Dynogest, you will put her on the pill, but you also have to give her the option of oocyte vitrification if she's not in a relationship. You also have to give her the option of embryo cryopreservation if she's already married, but she's not looking at fertility. You cannot say, yes, the reserve is low. There's a possibility that you might have infertility. That your counseling and your options don't end there. You have to take it a step further to tell them what their options are. Is it fertility straight away if she's in the right, age group, as well as socially, medically, and psychologically she's willing to go for fertility, or it's fertility preservation. These are the only two things. She either conceives right then, or you give her the options of fertility preservation. When we're talking about fertility preservations, two options as of now which are viable. One is oocyte vitrification, one is embryo vitrification. Now, yes, in the future we are hoping we might get ovarian tissue vitrification as well, but it's not as validated as oocyte and embryo. So let's not stop at just making them aware and giving them the counseling options, but also speak to them about the options that they have. Thank you.
To improve the success rate in IVF treatment. His main areas of interest are cryoembryology, in vitro maturation of the oocytes, embryonic stem cells, andrology, and men's health. Dr. Krishna Chaitanya sir, he has studied and practiced in Australia. He also undertakes research work with Department of Reproductive Biology, Monash, University of Australia. He is also Indian Ambassador for Academic Affairs. Now I request Dr. Krishna Chaitanya sir to come over and deliver about this today's topic, myths in male infertility. Sir, please come.
All right. Good evening, everyone. So I think when Dr. Kavya said we'll do this topic, I felt it was a little bizarre, but I thought that is the need of the hour. It's always deja vu coming back to Warangal, and in fact, our Andrew Life concept, I would say, took off in the right sense from Warangal. It's been close to 5 years we've been running our Andrew Life clinic once every month. And thank you all for that wonderful support and the response we get. I think we get to learn a lot every time we come to Warangal and we see these different male infertile patients than what we see in Hyderabad. I think Warangal gives us a different spectrum of things, and it's a whole new experience every time we come. So thank you all for giving us that support and love. It's been close to 4 decades we all are practicing and having knowledge about the ART, but there are a lot of myths that we still come across. That's the sad state of affair, and I thought we should be throwing some light and coming to a consensus as to what the best practice that's right now that we are all looking at. So we all know, I think equally there's male female contribution. There's no women alone being the sole reason why infertility is on a rise. I think in the year 2022, what we all are wanting to look at is a self-gamete conception. Probably a decade or more, it was easy to offer a donor sperm conception. But now the technology, the surgical interventions, and our know-how about how to deal with the man is improved so much that I think there's absolutely minimal use of donor gamete conception. And in fact, we do our annual statistics, and we were surprised to see that we had a 3% usage of donor sperm in the last 2021 statistics. So I think we've been really at the forefront in ensuring that we bring technology to the reach of our patients. So what really changed is what we'll quickly rush through and then get to the core of this today's discussion. I think invention of ICSI really changed the way we practice male infertility. If this accidental technique, if it was not invented by the scientist Palermo way back in 1992, I don't think the men with severe fertility issues would have really seen the completion of their dream of parenthood. So I think thanks to the invention of ICSI, and I think surgical retrieval, the techniques, the improvement, and the surgical know-how, all of this is improved so much, where we have gone from teaser to now doing micro TESI, and that's really giving us good success rates. Cryopreservation, I think we can freeze anything, everything these days, and this really is a game changer and it helped us give the best success rates. The embryo culture systems are again understanding and practicing and knowing intricate things as to what gametes and embryos need in vitro and how we could give them the best support. I think we have gone a long way. So I think that's another thing that's really helped us get the best success rates, and deeper knowledge into understanding the reproductive genetics, more so with the male infertility, which is helping us. So with that background, let's move on to today's core topic. We wanted to focus only on the myths and see where we all stand. So the first question I thought, which is more pertinent, is the moment we see a man with a male factor, low sperm count, the first thing that comes to our mind is ICSI. You send them to a urologist. Most of the times the urologist has said, just do ICSI. There's not much that we can do with a man who's got 1 or 2 or 3 million sperm count. So is this right? And if you really see in the last 3 decades, from 1992 till now, the usage of ICSI is really dramatically, drastically going in a wrong direction. I would also raise my hand where, for various reasons, I would just prefer doing ICSI on all the couple who come to us than do a conventional IVF. And this was, again, a little eye-opener to all of us, published recently in 2021 by the American Society of Reproductive Medicine, where they wanted to, put across the, should we be doing ICSI for non-male factor infertility? Low eggs, endometriosis, advanced middle-aged women. There are so many other non-male factor reasons where we very conveniently want to do ICSI because we just do not want to next day sit down with the patient and tell them that, what, there was less fertilization or no fertilization. I think it's more of a fear. It's a myth. And this paper, it's free for download. It's so brilliantly written. I think there are at least some 12 scenarios they've dealt with which are non-male factor. And the message was very clear that ICSI is not improving the live birth rates. So ICSI for all is a myth. I think it's time for us to take a step back and probably look at simpler interventions, because even in now 2022, we still do not know if ICSI is safe and what kind of problems we are going to have in these kids born from ICSI still remains unanswered. I'm sure we all have seen wonderful success rates. Women with severe problems, long-standing infertility have come, we've done ICSI, they've gone home happy with pregnancy, the couple is happy. But what is the future of these children born out of ICSI still remains unanswered. So I think ICSI for all, I think, to be taken with a pinch of salt. So that is where I think there's some role the urologist, the andrologist probably have, and that's where, should we be treating the man even before we consider doing ICSI? And I think that's just a little overview. I think there are certain things that we can do to improve the sperm parameters and bring about a successful outcome. I'm not getting into the detail, but there is a scope to treat the man. And more so, there's enough evidence to say oxidative stress is one of the basic or a primary reason which is bringing in a huge issue and challenge to male the sperm, the gamete there. And I think treating this probably is going to improve the outcomes, and not improving it, just doing ICSI with these sperms which have been put through stress or ROS induced damage, fragmented DNA, could lead to serious issues. And there are quite a few successful experiments which have shown that there could be epigenetic errors in these children which are born to father who've had uh, issues with their sperms, and ICSI is not the answer. There are a lot of options where we could treat the sperm. It's just not about picking one sperm and putting into the egg just because we all have learned ICSIs. As a beginner, as embryologist, I'm sure if people have had a bit of training in embryology would agree with me. It's a wonderful experience to sit on that ICSI machine and do a little robotic work. Putting the sperm into the egg and see a beautiful zygote form and a blastocyst form is an experience, and I think only an embryologist can connect with that. But I think there's so much of science that's gone with ensuring that there's something that we do to pick the right sperm. There's so much that we do with female partner, right from that whole playing around with the reproductive endocrinology, the HPO axis, and the endoscopic surgery, so many interventions. But when it comes to man, take a semen sample, do ICSI, and the job is done. The man sometimes doesn't even know what's happened. All that he has done is dropped a semen sample and walked off, and of course sometimes has paid the bill there. Of course, is getting a heartache by looking at the bill the clinic is given at times, but there's so much more that can be done. It's a good news for the men, and there's so many ways we could actually ensure that we're getting the best quality sperm. But which amongst these is the best? Because OASIS has been working and doing research in almost most of these methods, and that is where we were one of the first clinics in the world to do this 4-armed RCT, where we divided men with raised sperm DNA fragmentation into daily ejaculation, TISA, MAX, and microfluidics. This paper was accepted in the recent ASRM, which happened in Los Angeles. We presented there. Right now, it shows as if all of them seem to be giving similar outcome: TISA, daily ejaculation, max microfluidics. And why we put daily ejaculation? Because this is an age-old concept. In a daily ejaculation, we probably start from the first follicular study and get the man to ejaculate on a daily basis. And we're taking it, and the sperm is not stored in the body for a longer time, and that probably gives you sperms with good DNA. Such an economical thing, a very basic funda, but we all want technology. We all want to run away and get new things, and that's where we wanted to see if that is helping, which would save the cost for the couple, and looks like it is. But this is still an ongoing study, but the preliminary data looks encouraging, and all the 4 arms seem to have given the same outcome. So sperm DNA fragmentation, I think I was also in this race where along with the basic semen analysis, get a sperm DNA fragmentation, because there's so much of data published. It says sperm DNA, if it's fragmented, it's going to affect the reproductive outcome. So we get the DNA fragmentation test for everyone. We intervene, we do something. I think, again, this paper published in the year 2019 really changed the way we look at it. I think there are only a limited indications where a sperm DNA fragmentation should be done. So that doing a DNA test along with a basic semen analysis the first time when the couple has come to your clinic is a myth. It wouldn't really change and improve the reproductive outcomes. There are people like recurrent implantation failure, recurrent pregnancy loss are probably the 2 commonest indications who should be directed towards getting the sperm DNA fragmentation test. I'll not get into greater details. So, should we be ordering routinely to everyone? The answer is no. The next myth is, fresh sperm is always better. Frozen sperm is not going to give you the best outcomes. Be it the donor sperm, as per the science and regulatory authorities guidelines, I think we all know why the donor sperm should be frozen. You got to quarantine it for 6 months, rescreen the donor for HIV because they've got a window period, and only a frozen donor semen sample should be used for whatever ART intervention we're doing. A fresh donor semen sample is a big no-no. And there are a lot of time my own colleagues have argued and discussed, debated with me, saying that no, fresh gives us the best, and we have the data in front of you. I think there's enough evidence to say that fresh or frozen, if you've done the right protocol, makes no difference. It does not fragment the DNA. It doesn't bring down the reproductive outcomes. And that's our paper published in Fertility Sterility, where we went a step ahead and we compared the fresh testicular sperms versus the frozen testicular sperm. Routinely at Oasis, 90% of our testicular ICSIs happen with frozen semen, because trial teaser happens, we get sperms, we freeze it, and then we start the journey with the female partner, not knowing if we're getting the sperm and starting the woman with gonadotropins. I don't think we're doing the right thing. The woman doesn't need to suffer when the issue is with the man. So freezing the testicular sperm is a wonderful thing. Cryopreservation is helping us. Thanks, cryopreservation, for all of that. And that's our experience in the last 13 years. It doesn't bring your reproductive outcomes down, and your live birth rates are similar to what a fresh testicular sample would do. So urging all of us here in the room, if we are wanting to do testicular sperm aspiration for whatever indication it is, please ensure you contact one of the fertility centers. The embryologist is there to take the tissue. Go back and freeze the sperms if they are available, and you can do ICSIs with it, and the outcomes are no different. And I think that's something very, very recent that we've introduced at Oasis. There's a new device called sperm vitrification device, because we're doing so many microtecies. This device helps you freeze even if you get 5 sperms. And you could just freeze it, and then it's sitting in those small little circular things. You could just pluck the 5 sperms from those circular devices. It's made so easy. It's an Israel technique, and we've successfully implemented this, especially in people like Klinefelter syndrome. Even if you get sperms in micro-TC, they're single digits or double digits at times. And, doing ICSI is an absolutely painful job for the embryologist. We give up donor as an absolutely easy option. With newer technologies like sperm VD that's come into the picture, I think we got to take a step back. Donor is not the first option. So few little other common things, should we be treating the woman first and then look at the man? The answer is no. There's enough evidence to say that we need to start treating them as a couple. There's moderate level of evidence which says both need to start the journey together. Without a semen analysis, we would not even want to give folic acid or any kind of induction to the female partner. There's no age limit to the man, unlike where we think women has an age limit of 37 and above. We say she's advanced. There could be a pyramid, varied issues that are going to come up. The answer is no. Now the research says that men also age. Men also have issues with advancing age. I'm sure we have seen all these celebrities who have fathered their children at a very, very late age. And we thought men would never age, but I think the recent evidence is going against it. It's not the fecundity that's coming up. It's not that they're not going to have pregnancies. It's the health of the child and offspring is what we're worried about. So such children born to advanced fathers at a very high risk of neurobehavioral disorders, especially autism, schizophrenia, all of these are going to go up. Thanks to the ART bill, which has put a cap on the male age, which is 55 now. After the age of 55, we cannot be offering any kind of treatment, be it IUI, IVF, to the couples who come to us. So there is an age limit for the men, and 40 is a safer age. After 40, there are going to be some changes, and after 45, I think the issues are going to go up. And that's what we published at ESHRE this year at the Milan meeting, where we looked at the outcomes of the men with advanced paternal age, where the women were younger, but men were 45 and above. If you look at the control group where no intervention was done, the live birth rate was only 42%. But if we did a match to microfluidics, which would obviously help us with the best sperms, I think we were able to give them a better outcome. So I think age of men is something that we got to really look at it. Teratospermia, even today, yesterday's OPD when I was sitting, there was a referral from some doctor saying that, teratospermia, they have, highlighted that and said, go, you need ICSI. Isolated teratospermia, if your count and motility is normal, you've just got 1 or 2% normal forms, please don't create panic to the couple saying that you will need ICSI. Because there's a flaw in the basic semen analysis we're doing. Nobody is going to sit and count the 100 million sperms that's there in the entire ejaculate. We make a smear, we count 100 sperms. In that 100 sperms, if you've seen 2 normal forms, jumping to a conclusion that they need ICSI probably is not right. And there are enough papers which say that isolated teratospermia do not need ICSI, and that's not changing the outcomes there. Role of varicocele in azoospermia, that's a newer thing. There's a point where we said do not do a varicocelectomy to everyone where we see a grade 1, grade 2. Now if it's with azoospermia, a grade 2, grade 3, we might want to repair, because this is Estevez who came up with this brilliant, nice systemic review which said that they can improve your retrieval rates are going to be better, and in fact there's a 30% chance where even the ejaculate will have the sperm if you see a varicocele in an azoospermic man, provided it's a non-azoospermic, non-obstructive azoospermia. Genetics have no role. We will not get a genetic test for male infertility, because the incidence in India is probably less than 5%. The answer is no. There's a very high level of evidence which says for all men with sperm counts less than 5 million, non-obstructive azoospermias, cryptozoospermias, you have to get a karyotyping and a Y chromosome microdeletion. The incidence is slowly rising because we are testing these men nowadays. All of us are becoming more and more aware. In the past, probably we didn't do so much of testing and the incidence was shown low, but there is, in our own clinic, in a month, we do come across 1 Y chromosome deletion. It really helps us in prognosticating the patient. So I think that's another thing that we all need to incorporate in our practice. So retroviral cases, serodiscordant couple, women negative, the husband's positive for HIV, Hep B. We do not want to treat because we think that, we don't want to convert the lady. She's negative. Why involve her in all of these things? Use donor sperm. Again, the current evidence says we don't have to do that. In fact, even it was a new learning for me. The new HART guidelines say that we can even allow for a natural sexual intercourse with some prophylactic medication, and they can conceive naturally. So doing an IUI IVF is an absolute safe thing. There was a systemic review meta-analysis till date. Doing an IUI or IVF ICSI on these serodiscordant couples, there has not been a single case of reported where the woman has turned positive post-intervention. And that's been our experience at Oasis in the last 13 years. We've never turned down a high-risk patient who's been positive for a viral infection. We can, but again, the thing that we need to know here is, you got to be careful. Their viral load should be undetectable. It can't be offered to everybody randomly. You got to look at their viral load, CD4, CD8 counts. If it looks like controlled disease, then an IUI IVF probably will help, and the conversion is not going to be really on a higher side. Collection difficulties is something that we all routinely see that. You could freeze the semen sample if you really think they're high risk. You could do teaser on the day of the procedure. Donor is never the option. Let's say accidentally on the day of ICSI, you've realized the person is not collecting a sample, nothing was frozen. Teaser is not something that you can do at that point. You can still vitrify the eggs. Offering donor sperm when there's collection difficulty in the current day is unacceptable. So finally, to conclude, I think involve the man from the beginning. Infertility is not a woman's problem at all. There's absolutely so much that can be done to the man even before we can uh, ask them to go for an ICSI cycle. ICSI is not the sole answer. For especially for a non-male factor infertility, doing ICSI is again shown to be not beneficial. When one ICSI cycle fails, do we directly jump to donor sperm? The answer is no. There are a lot of interventions where we could try and do like max microfluidics, which can help us get the best success. Whenever we're doing TISA, it has to be done with frozen backup. Otherwise, please do not just do a trial TISA where a histopathology says there's normal spermatogenesis and you want to repeat it. Not acceptable. At the end, the main point that I wanted to share with you all, donor is not the first option. Donor sperm is always the Z option. There are A to Y, multiple options that we could discuss with our couples and then look forward. The success is all going to be the same. You just need to have the right expertise to handle it. So I think I'll end the thing there. Thank you so much. Be more than happy to take questions, but I think I was also asked to have a little interaction with you all. We all know the new bill came. Finally, we have a bill, we have a regulation that's going to guide all of us and help regulate the way we're practicing infertility in the country. I think the inspections in Telangana are going on a bit. We slowed down, but nothing has stopped. I think we are due to come to Warangal. We've just been a little lazy to travel to Warangal, but very soon you'll have us coming down to Warangal and do that. Because, we are a mix of people here. I've got very senior renowned IVF specialists here. I've got gynecologists as well. I thought, I'll leave it as an open forum. If there are any specific questions, burning issues that you people have, not that I'm the expert, but whatever little I have learned in the last few months being with the ART people, the inspection team, I can share my experiences and guide you if needed. If there's something more that you want to do it beyond this session, I'll be very happy to interact with and help you with whatever you people want. But it's very simple. The draft is open to access for everyone. It's very easy to understand. People who are coming to inspection are just following that. We just want those little points given in the draft to be practiced in your clinic, and nothing can stop you from getting your inspection through in a smooth way. But I'll be very happy to take question if anybody has. So I had a question. All right. All right. So I think I don't know if we can keep this as an interaction thing at a later point. Wonderful. Thank you.
Thank you, sir, Chaitanya sir, for giving elaborate details about the myths in the male infertility. Now, the last program of today is panel discussion. In this panel discussion, the topic is mind-boggling cases, case scenarios. I request the moderators, Dr. A. Narasimha Reddy, TCOG President, and Jalgam Kavya Rao. She is the consultant in Oasis Warangal, to carry on this program. And the panelists are, the list is big. Dr. Sanjay Rani, Dr. Sri Lakshmi, K. Srinivas, L. Radhika, and Shreya Gauni, Soumya, and Vasavi Reddy. Today's panelists. And I request Dr. Jalgam Kavya Rao to introduce about Dr. A. Narasimha Reddy, sir.
Thank you, Durga Madam and Krishna sir, for an elaborative session which detailed everything about from adolescent girl to the reproductive age group woman, and also Krishna sir, which has given much more details about advanced fertility treatments like microfluidics, MAX, and DFI, and everything. So I thought I should just discuss the real case scenarios which we have dealt in OSS personally, and I wanted Dr. Nasimha Reddy sir to moderate the session along with me, sir. But sir wants to make the show a little more interesting and wants to take the panel discussion side. So Dr. Nasimha Reddy sir, please, we welcome you. Sir is the managing director at Warangal Hospitals. It's a 100-bedded hospital established in 2007. We everyone know that. His theoretical command comes by having worked as a professor at KMC Medical College for 5 years, working at CKM Maternity Hospital for 18 years, and Vice Center, a private clinic in Warangal for 10 years, which has strengthened and his approach to solve cases of infertility. And sir is actually the backbone for all our infertility practitioners, which I can mention. I'm very much thankful for Dr. Nasimha Reddy sir, extensive support for OSS for its 5 years, which is there for today. And my next panelist, Dr. G. Srilakshmi Madam. We welcome you, Madam. Dr. Srilakshmi Madam is a renowned gynecologist and fertility specialist. She's medical director of Srilakshmi Test Tube Baby Center, which I remember when I was studying MBBS. We are very happy to have you, Madam. Now I welcome Dr. Kottagattu Srinivas, sir. Sir, please come over the dais. Sir is the managing director of Surya Fertility Center, Hanamkonda. The next panelist is Dr. Shreya Gauni. She's the founder and medical director of Matrika IVF Center, Warangal, Telangana. She did her master's in reproductive medicine in UK, diploma in reproductive medicine and embryology from Kiel, Germany, fellowship in infertility from IMA, from OSS Fertility, and she was the gold medalist in our batch. And she did her fellowship in IVF from Gurgaon and fellowship in minimal access surgery in World Laparoscopic Hospital, Foxy certification in advanced fertility from Mumbai, MS from Chelmed Anandrao Medical College, and MBBS from KMC Warangal. And she's contributor for many ISAR fact sheets and PG training programs. We are very happy to have you, Dr. Shreya. The next panelist is Dr. Vasavi Reddy. Please come over the dais. Dr. Vasavi Reddy is a renowned obstetrician, gynecologist, and specialist in reproductive medicine. She is director of Vasavi Hospital and Fertility Center. She did her MBBS from Pratima and MS from SVS Medical College, diploma in reproductive medicine, and ICOG fellowship in ART from Chennai, fellowship in laparoscopy from Chennai, and embryology from Singapore. Thanks. And our next important panelist is Dr. Rajni Madam. Please, we welcome you over the dais. Madam did her MBBS and MSOG and also Masters in Reproductive Medicine from UK. She is the Assistant Professor of MGM Hospital, Warangal, and consultant at Mahi Hospital. Her special interest is in high-risk pregnancy and infertility. She has published research papers in national and international journals, and Madam has very much interest in her infertility cases, which she will be discussing in the coming. So, welcome you all for today's discussion. So the whole point of having a case scenarios with all the expert panelists is only to give a message to the whole community that how to deal each and every case. So my first case comes here. A female aged 28 years and a male 34 years who are married for 8 years and they are with primary infertility. She is a case of PCOD with irregular cycles and PCO morphology on ultrasound examination with no evidence of clinical or biochemical hyperandrogenism. Coming to the medical history, she is hypothyroid on medication since years. No significant family or personal history. And they underwent multiple failed ovulation induction cycles with oral agents and gonadotropins at multiple clinics for 4 years. HSG, there is a bilateral tubal patency. She also underwent 4 cycles of IUI, and she was given letrozole 2.5 mg for 5 days and urinary FSH 75 for 2 to 3 days. Ovulation was documented. Endometrial thickness and pattern were optimum as per the scan images. And there were no details about the semen analysis. So it's been 7 years she started to try. So looking at the case history, I would request Dr. Shreya to take up the question. What further details do you expect from the couple?
Yeah, So she has already undergone multiple OITI cycles. So I'm assuming that the semen analysis would have been normal, right? And she's already undergone 4 IUI cycles. So the gynecologist would have seen that the semen is normal. I personally don't believe in IUI for PCOD patients because the problem is anovulation. So I would not have, even gone for those 4 IUI cycles. But I understand that guidelines say 3 to 6 cycles, but it is selective as to whom we can apply to. So I would probably evaluate her for IVF next.
So going to the further evaluation, her AMH is 8.6, FSH and LH are normal, but the FSH-LH ratio is high. And vitamin D levels on slightly on lower side. Her TSH is 2.3, prolactin is normal, and glucose tolerance is normal. She had a hysteroscopic evaluation in 2018 where the cavity is normal and the laparoscopy which revealed bilateral tubal patency. There was a history of ovarian drilling. And coming to the male history, the male partner is 36 years. She is a government employee, normal BMI, no other important significant history. His analysis in 2018, which has 23 million per ml, 37% rapid motile, normal forms are 11%. So as Dr. Shreya said that male partner would have been normal. So the one most important thing is whenever we are dealing with an infertile couple, it is always important to have a sperm analysis in hand. So Dr. Srilakshmi madam, looking at the history, madam, what do you want to go about with this patient?
Yeah, now she has already had 4 cycles before and 2 cycles here, so total of 6 cycles. Actually, that many cycles of IUI is also I do only 4 cycles of IUI before I consult the patient for IVF.
Okay. So for everyone, how many more IUI cycles are justified in this scenario? Pregnancies resulting from IUI occur during first 3 to 6 treatment cycles. Most women conceive after 4 to 6 cycles of IUI, and the cycle fecundability declines half to 2/3 thereafter. So the NICE fertility guideline says up to 6 cycles, which is 2004. And this is an IUI review and systematic assessment of the evidence, which are global recommendations. And they say that in couples with an indication for IUI, at least 3 consecutive IUI cycles should be performed, which is a moderate quality evidence. And when there is insufficient evidence to recommend a maximum number of IUI cycles, it is also an moderate quality evidence. Looking at the number of IUIs in this particular figure, less than 35 years when the female is having good ovarian reserve, 4 to 6 IUI cycles. More than 35 years with average reserve, it is 2 to 3 IUI cycles. More than 35 years, it is IVF. So I think all my panelists are agreeing with this, or anyone has any other opinions? IUI completely no.
Use mic.
For PCOS, I do not, like the problem is the anovulation, the egg. So if I tell my patients the same thing, that if you're able to walk, what is the need for you to have a wheelchair? So for the sake of trying, maybe there are some, cervical factors or, anti-sperm antibodies, which we can't test these days. So maybe couple of IUI cycles if the patient insists, but not 6.
Okay, sir.
Here in this case scenario, probably there is no role because she is ovulating, already underwent 6 cycles of IUI. But the problem here is the quality of the ovum. Quality of the ova which is being released. Suppose in case if you wanted to opted for any hysteroscopy and diagnostic or for any other reason, I don't say that it is indicated, if you are doing it, if the patient is associated with any of the symptoms of hirsutism, may not be having the levels, DHA, testosterone, everything may be normal, but still patient has got a acanthosis nigricans and the hirsutism, probably you may be justified in doing ovarian drilling. This is a take-home message and my experience. I have done few of these cases where the clinically she has to be either of these two things,
Hyperandrogenic.
acanthosis nigricans and hirsutism. As far as the drilling is concerned, practically every one of us know it, but overdoing has to be stopped.
Yes, sir. So hyperandrogenic PCO, sir says that laparoscopic ovarian drilling can be considered.
What are, suppose if the patient has got these two things.
Yes, sir.
Yeah, this is a case of PCOD. So, very important thing in ovarian stimulation. What drugs previously she used? That is very, very important in PCOD cases. What we are using previously, letrozole or metformin, like that. But if we use gonadotropins, it's very good quality of eggs we are getting. So if we see with the gonadotropins, highly purified gonadotropins, we will get good quality of oocytes. Then we will do IUI, we will get more success in these cases.
Agree, sir. So the gonadotropin induction cycles are more
Even
favorable.
PCOD, low dose, like say 75 units, like that, we are getting good number of oocytes in PCOD case.
Okay. So coming to the laparoscopic ovarian drilling, Rajini madam, do you have anything to tell about this?
Definitely, laparoscopic ovarian drilling has got a good effect in PCOS cases, basically. But as a practitioner, I'm always against surgeries initially for the fertility patients, especially. If it's a case of PCOS with AMH value below 10 and not too much of LH and all, I just try with normal cycles for first 2 to 3 cycles. If they are not conceiving in those 2-3 cycles, then we definitely, as Sir said, yeah, gonadotropin protocol, if we can follow, that would be better. Even after that, if they are not responding, only then I suggest basically LOD, as Sir said, hyperandrogenic conditions and also high levels of LH definitely adds on to the results. But these days I've seen post-drilling, patients are coming up with good results actually.
So LOD can be alternate to gonadotropins where the patients are not affordable for the injections. Also, it can be in the selective cases like high LH levels, normal BMI, when laparoscopy is otherwise indicated or who cannot have intensive follow-up with us. So LOD should not be a first-line therapy except for few conditions. And we all know the advantages of LOD or spontaneous monoovulation, as effective as gonadotropins, requires less intensive monitoring, no risk of OHSS, no increased risk of multiple pregnancy, but the disadvantages remains iatrogenic additions and decrease in the ovarian reserve, which has to be taken care of. So as we know the rule of 4 punctures and for 4 seconds with 40 watt power setting, it delivers 640 joules of energy per ovary, the lowest effective dose. Coming to the subclinical hypothyroidism.
I have a question here, Kavya, if I'm not obstructing you in between. So this is to you, sir. Is it mandatory that we follow the rule of 4 for all the cases irrespective of ovarian volume and stromal volume and all?
If the ovarian volume is more, probably you are justified in putting more than 4 also. But the thing is, where you are putting is also is more important. Where you are putting the punctures. And as it said, it is a 4 punctures. And what is the depth? 4 millimeters is the depth. And 4 seconds is the one, 40 watts. What type of current you are using it? It is should be always a cutting current only and only, and anti-mesenteric border is the one has to be chosen, not on the anterior surface or on the posterior surface, so that you can avoid adhesions, especially if you put punches on the posterior surface of the body, it is bound to fall on it, it's bound to get adhesions, so that has to be avoided.
I think the scan will tell you a lot. You see the antral follicular count. So then you can decide whether, we have a lot of patients with PCOS plus decreasing reserve. it's better to abstain. Sometimes we see only antral follicular count of 10 to 12. So if they're not responding to gonadotropins, it means that receptor itself is a problem and not
So
probably
you say that if the antral follicle count is more,
and then they're not responding at all to ovulation, then that makes sense ki, we have a lot of patients who have antral follicular count zyada and AMH is also more, but then they do respond to drugs, then I don't think they require any lab drilling. And also sometimes this number, we see the antral follicular count, if it's more, the stroma is more, then probably 6-7 punctures is fine. But if the antral follicular count is less, maybe not.
And many a times, even drilling one ovary has shown many excellent results, like we see on ultrasound, like Dr. Shreya has said, if we don't find that much antral follicular count, even drilling one ovary has shown benefits also. So we can't have a single setting for each and every patient, depending on the antral follicle count, the AMH levels. All these things have to be taken care when we are doing the ovarian drilling. So sometimes many times we have done drilling only on one ovary, and the patient has she starts ovulating from the other ovary also. So it is just the microenvironment we are trying to change. And whenever you put the puncture, you should put it on the stroma. So many times we keep it wherever we can, but we should put on the stroma, see that the microenvironment, androgen microenvironment has come down. That will help in ovulation.
One more thing is, rule of 4 is very, very important. We are seeing so many cases, they are underwent ovarian failure. By doing more punctures in case of PCOD drilling,
they'll end up
so it is very, very important. Cautious drilling is very, very important.
Agree,
we are
sir,
getting so
agree.
many cases of ovarian failure.
Coming to the subclinical hypothyroidism and its impact on fertility, as we all know, they will be having menstrual irregularities, anovulation, infertility, miscarriage, and in pregnancy also, there are reports of abruption, preeclampsia, preterm labor. Coming to the fetus, abnormal cognitive function, neurodevelopment delay, low IQ, and low birth weight. So, according to the 2021 European Thyroid Association guideline on thyroid disorders, prior to and during assisted reproduction, if the TSH is above 4, the levothyroxine therapy is recommended. And if it is between 2.5 to 4 also, it is recommended. So, and the next is vitamin D in PCOS. Vitamin D, I think there are, the importance for the vitamin D in especially PCO, I have kept is that there is lot of improvement in the PCOD condition when the woman is supplemented. Like we can see its impact in the decrease in the SHBG condition and increase in the androgen action also. And there are changes in the insulin resistance, which is coming down, and which is giving the ovulatory dysfunction in PCOS, which is changing. So suboptimal levels suboptimal levels of vitamin D levels in PCOS were implicated in disrupted reproductive hormonal balance, which gives an overproduction of AMH and accumulation of pro-inflammatory advanced glycation end products and formation of reactive oxygen species in the ovarian tissue, leading to abnormal folliculogenesis. And there are many studies which said that the effects of vitamin D supplementation is directly on the metabolic profiles, gene expression of insulin, and lipid metabolism in infertile PCOD condition, and they are the candidates for us to supplement. So vitamin D in PCOD, I think everyone are on same word. So let's take this story further. And this lady had one IVF cycle in 2019, which is an antagonist protocol. She had 9 days of stimulation with Gonalef, 225 international units, and the trigger given was Leupride. Her trigger E2 value on the trigger day is 2000, and 18 oocytes were retrieved. Out of 18, the quality was told to be good, and there were no reports. Assuming all the 18 were mature, ICSI was done. 18 fertilized, and 11 day 3 embryos, which are C-grade embryos, discarded, and there are no available embryos for transfer. There are no reports provided. So this is the information we have. And sir, Srinivas sir, so this lady is with us, and what leading questions can we ask the couple to get some history, because most of the times we don't have the original reports and we go with the patient words. So do you think the oocyte quality was bad? That's the reason why the patient didn't get embryos? Or do you think that there is something about the sperm also?
Yeah, definitely. Already 18 oocytes retrieved, and finally there is no embryo set lost. So definitely we go for semen analysis techniques. Then we'll know the result exactly what happened.
Is it only semen analysis, or Dr. Vasavi, do you want to do any other advanced test for her?
DFI.
DFI, sperm
DFI.
DNA integrity test.
I think in this patient, if I'm not wrong, absolutely sperm count is normal. Morphology also somewhere around
DNA
11,
fragmentation was not
11%.
there before
So-
On analysis, 26 millions, motility was 30%, and morphology was 11% is mentioned. There is no details about the sperm DNA healthiness. So after coming to the OSS,
Any habits, man
DNA
has got
fragmentation.
any addicted to any alcohol habits, some other thing.
Personal history from the
Personal
male
history,
side, if he is
personal history,
diabetic,
because
if he,
such type of scenario, usually morphologically they do very well. They do semen analysis reports will be having. This especially gutka chewing is most rampant.
yeah, sir.
Especially normal semen analysis, the woman won't conceive. Once they stop doing it, the majority of them they conceive spontaneously.
Even in OSS, this person had a sperm count of 30 millions per ml, motility of 15% progressive and 2% normal forms. But when the DFI testing was done, it is 48%. Coming to the female, it is everything normal except for the AMH, which is 5.1. So what causes high DFI, and whom do we check, and how to go about managing the high DFIs? Dr. Shreya?
So actually, I wouldn't have done DFI also. Because see, we do DFI, we don't do DFI, the treatment is the same. We ask them to do frequent ejaculations, ask them to do, take high antioxidants and maybe wait for 2 or 3 months. The point is, even if the DFI is high and we're going for, IVF later, sorry to, be, negative about this, but I don't believe in DFI because we can't kill the sperm, see which sperm is and which sperm is bad, and check and take it into the egg. Because whatever other modalities we have to, check the sperm quality, like, you use microfluidics and all that.
So you
I
mean
think
without doing the DFI testing, we
DFI
should switch
without
over to
DFI
microfluidics?
testing, I would ask them to, take 2-3, because even if we do a DFI, what are we going to tell them at the end of the day?
No.
This is only a way to explain to the patient that
Yeah, for counseling and
No,
for
even a
counseling
normal
purpose.
looking sperm might be having abnormal
DFI
fragmentation.
more than
So
25%
yeah.
is going to give
Yeah.
us low quality embryos.
So, but
It's
this
just
is
a way
the
to
no. She
tell
has
them.
already undergone one cycle of IVF, and she has failed, and 18 oocytes, no embryo to transfer. Then definitely, I would suggest
I
further
wouldn't have
evaluation
gone.
is definitely
So
required.
yeah, actually, Shreya, what happens here is 18 oocytes, which are complete cleavage stage arrest, which no blastocyst. I think there is a deep sperm issue where.
Definitely there's a sperm or an egg issue, which we can't, there
Do you
might be a
think double
genetic
density
issue
can do
also.
that?
I don't know. I'm saying that we can't differentiate whether it was a male or a female problem which caused the arrest. Number one point. And number two, DFI will not help us treat the patient. It will just help us counsel the patient.
And also decide about the male plan, I feel.
Male plan, like the same, it will be the same, right? Antioxidants and frequent ejaculation.
See, we personally,
Now,
sir,
in this case, this husband was never treated before.
Yeah.
And he was never investigated. Thinking the semen parameters where everything was all right, he was never
Yeah, I don't
treated.
think he was
Antioxidants
stressed
to
upon
the-
the antioxidants as much as the care was taken towards the female. I don't
Yeah,
think
so now at this center, maybe 3 months of antioxidants, and of course, you might have done that.
And one more
Male
important thing
examination
is,
detailed male examination is required here.
Yes, sir, agree,
DFA
sir.
is very high. But the
and
thing
one
is,
more important thing, we have to check out our incubators first. Contracon is there, calibration is there. What is the temperatures regulating or not? First of all, we have to check our lab thoroughly.
In this case, the embryos have actually formed, and the slide shows they were cleaved, but finally there was no growth, I think. So, no, if we start speaking about why didn't the embryo grow, then there'll be 10 number of factors coming, starting the quality of the lab, the embryologist, the clinician, everything. So many parameters have to be taken care of to get a good embryo. So that will be entirely different chapter. But now this we are focusing on the patient and what is the problem with the
Yeah,
husband or the
exactly.
wife.
And also about the causes for high DFI could be infrequent ejaculations, aging, infection in the male reproductive organs, cancer, pollution, toxins, radiation, high intake of caffeine, recreational drugs and medications, varicocele, raised testicular temperature, smoking, stress, and also increased BMI. Also could be poor diet. So all these things will be a reason for an increased DFI, and the indications from various studies remains fertilization failure, poor embryo quality, implantation defects, spontaneous abortions, and congenital malformations. So I think if you have enough of literature suggesting advice for DFI, at least for counseling, and also the sperm plan to be taken forward. To be anything, sir?
Yeah, just I wanted to add one thing. You have mentioned that hypothyroidism subclinical. You want to bring down to up to 2.5 in each and every patient, in all the infertile patients, or only those failed IUI or IVF,
All reproductive age group women.
or regular patient. Suppose in the what is the dose you advise?
Dose depends upon the thyroid levels or
Yeah,
TSH
it's already
level.
it's 4, less than 4.
No,
When
less,
you are subclinical means when you are using it's
Yeah.
less than 4 only, because in a normal gynecologist when it is less than 4.2, they are not doing anything to the female.
the minimum
But
recommendation
whereas
is
the
25, sir.
infertile specialist, you are bringing it down to 2.5. Then what are the criteria? Is it T3 is normal? Is it T4 is within normal range? Is it TSH is 4 less than 4.2? In that scenario, do you add thyroxine? What is the dose? If at all you add it, how long you are going to add it?
So, sir, example in a scenario where a lady is having a thyroid of 4, TSH of 4, her T3, T4 are normal. The recommended dosage for infertile women is 25 mcg, because we have our endocrinologist also in the loop. It's not only the gynecologist or a fertility specialist, but a minimum dose of 12.5 to 25 mcg is directly kept for them. And once the patient is conceived, her TSH again rises up. Again, the dose has to be added. We add 12.5 or 25 more to the patient once she is conceived.
So I recommend 25, like
25.
the initial dose, not 12.5, because 12.5, like for fertility patients, it's like it doesn't work.
Actually, I'm not dealing with any of the XC or IVF patients. I am more concerned with the IUI patients, where I fail to do it. If it is 4 or 4 point less than 4.2, I look at the TSH, T4 levels. If they are high normal, I won't add anything. I won't add anything. If it is T3 also, it is high normal, I won't add anything. If it is both of these two things are below the midline, below the off, probably I may be justified in adding 12.5 micrograms a day. And I'll recheck after a few days, I'll recheck only T4.
Only T4.
I won't do a TSH again. I'll T4. If it is within the mid-range, it is not the too high or it is too low, then I'll be satisfied in doing IUI. That too in failed IUI cases.
So this guideline is from 2021, which is very recent, sir. For all assisted reproductive group of women, the guideline is actually suggesting us to support the patients even between 2.5 to 4.
And especially if the patient has miscarriages before, then it is definitely indicated. Not only in recurrent IUI failures or IVF failures, if she had even one miscarriage, I think maintaining the TSH levels 2.5 to 4 or less than 2.5 is ideal.
So treating the high DFI, treat the underlying cause and antioxidants for 3 months, frequent ejaculation, and best sperm selection methods like microfluidics and MAX. And here we gave CoQ and vitamin D metformin for 6 weeks as pre-treatment for the female. The protocol remained antagonist because she is a PCOD, and stimulation was started with FSH and HMG in combination. And we added growth hormone. It was 11-day stimulation, and total dose of gonadotropins is 1050 and of FSH and 1400 of HMG. It combined dosage of 2500 Pre-trigger values, the E2 was 6,720, and the trigger given was triptorelin 0.2 for 2 doses, 12 hours apart. We added a little HCG 1500 as a dual trigger here, and the OPU was done 35 hours later. The reason why the timings are also mentioned about the trigger also is because we don't have a previous report about 18 oocytes. Were they mature? Were they immature? We don't have any details. And on microfluidics was done on fresh ejaculate, 32 millions per ml and 70% rapid was chosen, and the morphology was same. And husband was given antioxidants for 2 months and was advised daily ejaculate last 10 days before ovarian stimulation. That means from the day one the stimulation is started, we advised him to ejaculate daily. Retrieved 18 and 17 were mature. All are dark oocytes with large perivitelline space and debris. On day 3, 13 embryos, grade 3, 1 grade 2 and 1 grade 1, which have more than 25 fragmentation. 2 embryos are frozen on day 3, 1 6-cell grade 2 and 1 8-cell grade 3. All other embryos were cultured to day 5. Only 1 blastocyst of grade 3 is obtained and frozen, and FET cycle is ongoing. Dr. Vasavi, your thoughts about growth hormone in PCOS?
Generally, I don't give growth hormone. But I tried growth hormone 1 year back. Like it is like, it does affect maturation of oocyte quality and egg quality. But the thing is, the dose of FSH and LH which I'm giving is almost the same even if I'm going giving the growth hormone also. So generally, growth hormone plus FSH like HMG, so it is not that cost effective for few patients.
Okay,
So they're
agree.
not affordable to give both growth hormone and gonadotropins.
So looking at the oocyte quality here in this particular case,
In few cases, I go for growth hormone.
Yeah, agree.
In few, I avoid.
So growth hormone causes activation of P13K AKT signaling pathway and reduces the apoptosis and protects the granulosa cells from the oxidative stress injury, improves oocyte quality and IVF outcomes. So pre-treating the patients in PCOS, looking at the weight loss, we should advise the patient for weight loss along with the metformin. And we should improve the patient's menstrual frequency. It also improves the ovulation, pregnancy, and decreases the miscarriage rate. And coming to the metformin, Madam, Sri Lakshmi Madam, your take about the metformin.
Yeah, metformin is the drug which has shown good results in PCOS, especially if the patient is obese and trying, even after lifestyle changes and all those things, metformin has shown after, during the ovum pickup, we have seen good number of oocytes, the quality has improved. So metformin is ideal drug, but we should always start with the low dose and go up to 15. I usually go up to maximum 1500 mg.
So the recommended dosage is 500 mg 3 times a daily, that is 1500 mg per day, starting before the stimulation. The whole point here also is important about preventing the ovarian hyperstimulation for this female. So it also increases the insulin sensitivity, decreases weight and BMI, BP and LDL cholesterol levels, and improves the chronic inflammatory state in the woman with the PCOS. We have enough of literature which is suggesting that the clinical pregnancy rate is improving with metformin, but there is no difference in the live birth. Coming to the myoinositol treatment in women with the polycystic ovarian syndrome, myoinositol, I think now that the pharma brands are in combination with myoinositol and metformin, so I don't think this should be a separate discussion for us. 2 grams twice daily. So it is not about the quantity, but the quality that matters in this case. We can see there are 18 oocytes which were retrieved, but the quality was a concern for her. So we should aim about improving the quality for her. And also the protocol should be individualized for them, and consider checking DFI in cases of unexplained infertility, recurrent implantation failure, recurrent pregnancy losses, smokers, obesity, and varicocele. Male partners are to be monitored more closely. Let's not ignore the male.
One more important thing is FET is important for these PCOS cases. Freeze, all the embryos should be freeze.
Yeah, sir.
Yeah?
Yes.
Should not transfer in the same cycle.
Yes, sir. I
In
agree.
PCOD
No
expression.
fresh transfers, all are frozen
Yeah.
embryo transfers for.
Yeah.
Case 2, she's a 32-year-old female and 37-year-old male, married for 7 years, secondary infertility. Her BMI is slightly overweight and menstrual cycles are regular. She is hypothyroid on medication. Her first pregnancy was a spontaneous pregnancy 6 years back. She delivered a twins, male and female child, and male child expired after 2 years of birth. And there was a history of lab tubal sterilization done 6 months back. The tubal recanalization done sterilization done 6 months post delivery. I mean, after the delivery, she was sterilized, and 4 years after that, she was again recanalized. The HSD still shown there is a bilateral tubal block. So they are physically, mentally, emotionally tired, and they are with us. So, Rajni madam, what's your opinion about immediate postpartum tubal sterilization?
Generally, we don't suggest immediate postpartum tubal recanalization. According to Government of India, we say at least take 1 year time. If at all it's a second baby, and if it's a first baby, we ask for whether the first baby is 3 years when she's for second delivery. So we generally advise postponement of sterilization at least for 1 year.
Oh, agree, ma'am. And what about if you were given an option to choose between a tubal recanalization and IVF? What are your thoughts, ma'am?
When we have to make a choice, first we have to go through the age of the female and also the ovarian reserve, and yeah, of course, their mental status, emotional status, and all, and also the method of the technique they have used for the tubectomy and how many years has it been since tubectomy, and their affordability, of course. All this have to be kept in mind, and if they are in a good stage, and if they are willing for IVF and all, I would suggest them IVF rather than going for canalization, waiting for long, and being upset meanwhile.
Sir, any thoughts, Narasimha Reddy sir?
It's a debatable one, postpartum sterilization should be avoided, thinking that probably she may require recanalization. It's not so. After first pregnancy, suppose any woman or a couple wants, after first child, they would like to have the postpartum sterilization immediately after birth, it's absolutely no. After second, probably you may give an option that it's better to have it after 9 months or after immunization is over, or at least 18 months or so. But certainly not after 3 cesarean sections. Because already patient has got 2 live healthy child, maybe more than 3 years or old, and the newborn child is also doing well. If they don't want any more, there is nothing wrong in doing postpartum sterilization, because we have to justify on which patient you are doing it. So it's not a bad idea to do it, but it's if you do it on a patient who is asking for the first child, probably we should withhold. After second child, it's my thoughts. Probably people may differ with me. It is my thoughts of counseling the patient.
Okay, sir, thank you. So looking at the tubal surgery in the era of assisted reproductive technology, this is a committee opinion. Patient age, ovarian reserve, partner semen quality, surgical technique that was used to perform the sterilization, expense, chance of success, and reproductive preferences are essential elements in decision making. The other prognostic factors which are thought to predict include the final tube length and the site of the tubal reapproximation, like isthmic reversals may have greater success than the ampullary or cornual segments. The rate of ectopic pregnancy after tubal anastomosis was reported as 4 to 8% versus 1.4% for IVF. I think this point also we have to counsel them. And women who elect tubal anastomosis require early surveillance with the occurrence of a positive pregnancy test. If no pregnancy occurs within 6 months, an assessment of tubal patency is suggested again. So her past investigations, which was in November 2021, FSH is 9.2, LH normal, thyroid normal, and prolactin normal. First cycle IVF is in Jan 2022, no reports available. Assuming, according to the patient history, the things what she have told could be a long protocol. And she had been a frozen embryo transfer in Jan. And it was a day 3 8-cell stage grade A embryo transfer was done. And the beta HCG was 159 biochemical. Male partner 37 years with 15 million per ml and 5% progressive motility with 1% normal forms. Ultrasound revealed right and left testicular sizes, which is right grade 2 varicocele and left grade 3 varicocele, and his DFI is 35. So I think in the previous discussion, we didn't include the male partner yet. We were only looking at the female, but looking at the male, sir, would you still like to go for recanalization here in this view, sir? With the male history of 37 years and with only 5%.
What's the age? Patient's age?
She is 32, sir, and he is 37.
32 years. I will counsel the patient because somehow or the other the patient requires some time for the recovery of these sperms, at least for 3 to 6 months after bilateral varicocelectomy. Because in this patient, this gentleman requires not only grade 3 has to be operated, but subsequently it's a grade 2 is on the other side. It has to be operated on the both sides. There are some reports also are coming up. Even the unilateral grade 3 varicocele has to be operated on the both the sides. I prefer to do varicocelectomy in the first place. Then the option has to be given to the patient. It all depends upon how the patient reacts to it in this case. I won't prefer directly for the recanalization. If they want wait and see policy, probably I may go for recanalization in this issue. Suppose if they are not in a hurry and they want better results and they don't want to take any risk of ectopic pregnancy, I'll wait.
So I think when the patient...
refer the patient to ART.
Agree, sir. So when the patient was diagnosed with the tubal issues also, the male should have been evaluated simultaneously where we could have prevented the time for them for conception. So if the take home was about grade 3 varicocele should to be operated, even if it is unilateral, yes, we should have operated long ago when the female was actually treated for the tubes. But now after this failed IVF also, do you still want to go for varicocelectomy? Madam, Sri Lakshmi Madam?
Yeah, this is grade 3 varicocele.
Yes.
So definitely I would want to go ahead with varicocelectomy.
What all you want to counsel the patient before taking them for surgery?
Ideally grade 1 and grade 2, I don't suggest them for the procedure. But since she already had failed IVF cycle and she has undergone tubectomy recanalization and the husband is suffering with varicocele grade 3. So varicocele grade 3 needs varicocelectomy. But I would tell them that they may not be, because have the tubes been evaluated post-tubal recanalization? Are they tested again? Yeah. So HSG showed tubal
block after the recanalization.
So even after recanalization, since she has had a block, so the surgery was not successful. So she needs an IVF again. And once one IVF has failed, so like in the previous case, what we have discussed, she definitely needs this, husband definitely needs varicocelectomy to increase the DFI, what all abnormal sperm parameters definitely are going to be increased. But we have to see, like the slide shows,
so these are 2020 guidelines.
Yeah. So no, but the hormone parameters of the husband were normal, FSH, LH, testosterone levels. They had children before. Only this was for the secondary infertility. So that means he must be normal only. So it is difficult. Proven fertility and so many factors like tubectomy, recanalization, again IVF, and all
the
this
time is most important, I think, with this couple, especially because already a very thing is they lost their second baby. Also, they want to try naturally. They underwent recanalization. Again, now they were told about the varicocele, a surgery again. So I think let's discuss forward. So these are the ASRM guidelines. Surgical varicocelectomy should be considered in men attempting to conceive who have palpable varicoceles, infertility and abnormal sperm parameters, except for azoospermic men, which is a moderate recommendation level B. Clinicians should not recommend varicocelectomy for men with non-palpable varicoceles detected solely by imaging. This is strong recommendation. And for men with clinical varicocele and non-obstructive azoospermia, couples should be informed of the absence of definitive evidence supporting varicocele prior to ART. So conservative management of varicocele is recommended when there is no clear indication for surgery, along with regular follow-up by sperm analysis and hormonal profile for early detection and deterioration and advancement of the stage of the varicocele. reduced preoperative testicular volume, elevated serum FSH, diminished testosterone concentrations, and subclinical varicocele are negative predictors for fertility improvement in the surgery. So these are the points which we have to take in care. So investigations.
May I add on, Kavya? Recently, I've gone through a case where it was a varicocele of grade 2, and he had symptoms of pain, and then I said he was asking for surgery. Then, as it's indicated in books, that unless until it's grade 3, we are not supposed to advise them varicocelectomy. But still, I have sent him for an opinion to the urologist. And yeah, he got operated because he had some discomfort. But I could see there is a drastic increase in the sperm count as well. It was less than 2 millions, and after surgery, it was around some 28 millions. Maybe it's a abnormal report before.
Good surgical
or it's
hands could be,
I
ma'am.
don't know. But should be carried as a dictum that it's only grade 3 varicocelectomy. We have to take up the surgery, or we can leave it to the urologist's decision.
Ma'am, more than a urologist, I think if the male is not married, the decision can be the patient and the urologist choice. But if the male is married, we have to take the female history also into the account, and the infertility issue is, I mean, we have to treat them accordingly. If the female partner, like in this particular case, her AMH is 0.7. So
Basically, varicocelectomy, again, it's a double-edged sword. It can increase and it can drastically get down the sperm count as well. So because we're cutting off the blood supply, so the patient needs to know he can improve, or it can even get, very bad. Pain, madam, pain is always an indication for surgery. Pain is personal. You can't live with pain. So if varicocele is associated with pain, it's always an indication. But for infertility, again, it is, plus or minus, they need to know this can happen and that can happen as well. So if it's a 5%,
advising a semen sample freezing even before counseling a patient for
varicocele,
varicocelectomy is what which we should be doing, because all our patients, after they are back from the surgery, to our surprise, they might be landing into azoospermia or very less sperm counts. So, I mean, depositing their sperm and freezing their sperm is something which is secure for them. It should be advised.
As far as the grade 2 varicocele is concerned, unilateral varicocele, I don't think it requires any surgery. But the problem here is diagnosing the varicocele itself is a tricky issue. When you are seeing the patient, in what position you are doing. Even sometimes what will happen, patient, I diagnosed it as he doesn't have any varicocele. When I examined the patient after a few months, there is a grade 3 varicocele. How could I have missed? Because the scrotum was contracting. Okay. It's so tight, and the bad time I examined the patient and I presumed that he is normal. So patient scrotal sagging has to be present when you examine the patient. Suppose if that is not there, scrotum contracted, test has gone torn up, you can't find out. Even the varicocele, the patient has got a grade 3 varicocele also. This is my experience. Once I won't make any mention that he doesn't have any varicocele. I will examine the patient again after a few days, or when he comes back again after 1 week or so, then I will see the patient. So in that scenario, if it is present, definitely I go for it.
The advantage of being a male gynecologist is, sir, examine all his male patients along with the female patients, and I have that enough information, and I don't need to really think too much about them. Thank you, sir. And this lady has an AMH of 0.7 and an antral follicle count of right side 4 and left side 2 to 3, and she is having an endometrium of 2.5 to 3 centimeters in left ovary. Dr. Vasavi, what do you think about this female with a low ovarian reserve and a small endometriotic cyst and a very low ovarian reserve? Do all endometriotic cysts need to be operated?
I don't think the endometriotic cyst is less than 3 centimeters. You should not operate. That is the main thing. And AMH is also very important in this case. So if the AMH is, I think it's around
0.6.
Yeah, it is
0.7.
0.7. So if we operate also, first of all, it is not recommended. And even if we operate also, again, the endometriotic cyst may reappear. So the tendency of cyst is to reappear after 2 to 3 months also. So for this patient, other than operating, excision on drainage also I don't recommend. So
if in case she is not looking for a fertility aspect, and if this lady is with us, how frequently we are advised to actually follow up the patient, and if in case the surgery is advised and considered, so which method do you prefer? Fertility
These
and
ladies,
non-fertility.
unilateral endometrioma less than 3 centimeters size. Pain is not even the criteria, and she is not looking for anything. And probably that if it is suspect that whether it is an endometrioma or not, if the pain is not there. It would be in a simple hemorrhagic cyst, you might have mistaken. Because if it is an endometriotic cyst, there won't be some amount of pain, whether even on pressure, or even if you don't do it on a bimanual examination itself, you will be able to make out. Suppose that some pain is there, then I will go for the medical management only. There is no need for her to undergo surgery.
Agree, sir. Role of adjuvants in poor responders, Dr. Shreya.
So I have a question, sir. So I've been following a girl since she was 13 years. Now she's around 19 years. And whenever, I have started her on medical management, how long can we keep them on medical management, sir? Because she keeps suffering with severe pain abdomen every month. And how long can I treat her with medical?
There is no age limit as such. There is no age limit. You know, you have to alleviate the pain. Yeah, it all depends upon the how you are. You want to continue the diagnosis. If you have put the patient on diagnosis, it's so you have to tell the patient you are going to have the amenorrhea. Suppose if you are decided some reason or the other breaking, giving oral pills for 2, 3, 6 months, then stop in between. Again, you will be giving continuous oral pill because there is nothing in the cyclical oral pills are not going to work in these girls. But the thing is, you can give as many days as possible. But the thing is, you have to tell the patient, get early. You have to get married early and finish your family as early as possible.
Studies have shown where Dynogest was given for 5 years also, and it has proven to be safe. Ideally, many studies were showing up to only 2 years, but few studies have there where Dynogest was given up to 5 years and there was no other issue. So till probably patient, till she wanted to conceive, she was continuing that Dynogest. So 5 years.
Surgery for endometrioma pre-ART. In women with endometrioma larger than 3 centimeters, cystectomy is indicated prior to ART when it is associated with pain or inaccessibility of the follicles for the ovum pickup. Excision of the endometrioma is strongly recommended in infertile women when there is a suspicion of malignancy or when there is potential rupture during pregnancy or torsion of the cyst. Coming to the excision versus drainage, which surgery? RCOG 2017 and NICE guidelines compared with drainage and coagulation, cystectomy is associated with an overall lower recurrence risk, higher spontaneous postoperative pregnancy rate, particularly if the cyst size is above 3 centimeter in diameter. And CoQ treatment as an adjuvant in poor responder, Dr. Shreya?
Yeah, coenzyme Q is
Yes,
proven to
which increases the clinical
results.
pregnancy rates. And DHEA is also in poor responders.
I think many of you may be doing cystectomy for ovarian endometrioma, I think. So now there is a little bit of modification of doing ovarian cystectomy. After peeling of the cyst from the ovary, when you go up to the hilum, please don't pull the cyst from the hilum. Just leave a little bit of cyst at the hilum. If it bleeds, probably you coagulate the cyst only. You will be coagulating the cyst. See that you will not burn the hilum. So be careful. This is another way of preventing, reducing the antral follicles count. This is otherwise it's been propagated by a few of the gynecologists and surgeons. But pain is the criteria when you are doing not for the infertile patient. It's better to remove complete cystectomy.
Okay, sir. So CoQ, DHEA, testosterone and growth hormone pre-treatment in poor responders, we have enough evidence supporting it. CoQ is 300 mg and vitamin D, DHEA for a month prior to IVF cycle. Testosterone gel 1 puff per day, which is transdermal. Antioxidants to husband, and she underwent an IVF antagonist protocol with clomiphene 100 mg for 5 days from day 2 to day 6 and HMG 300 for 10 days with growth hormone and 10 days stimulation. And there are the trigger was HCG, which is a dual trigger HCG plus triptorelin. And we have done microfluidics on fresh ejaculate for him and 35-hour OPU. Expected are 7 and collected were 6, and ICSI was done for 5 mature oocytes, and there are 3 day 5 embryos formed here. And she had a live birth after transferring 2 day 5 embryos, and beta HCG is 956. So we have to choose the patients very wisely before advising or doing a surgery, and not every poor ovarian reserve should be advised a donor option here.
So why was an antagon cycle chosen in this patient? What was your idea like?
Ma'am,
Antagon cycle.
why not agonist protocol? Okay, fine.
Poor ovarian reserve.
Yes, ma'am. So agonist and antagonist protocol, anything can be chosen, but for her, I mean, the decision was not very strictly taken for antagonist. It can be an agonist protocol also, but the day when we start looking at the antral follicle count also, maybe the option of antagonist can be taken.
Ma'am, we can do progesterone primed also. It's showing very nice results. So I think the
Yes, protocol, yes, could be of your choice. Case 3, 37-year-old female and 42-year-old male, secondary infertility with BMI 30, regularly menstruation. They had a history of 3 IUI donor cycles which are failed, and 1 pregnancy IVF conception. Beta HCG was 318. So AMH was 2.3, FSH LH normal, prolactin thyroid normal, and male he had 3 million per ml, 1% progressive motility, ultrasound scrotum normal. It is a severe oligoasthenoteratozoospermia. What other investigations are to be done for severe OATZ case? Srinivas sir.
Ultrasound for scrotum, for varicocele, and DNA fragmentation test. Karyotyping also, very, very important. And total testosterone levels and other hormones. FSH, LH, serum prolactin, TSH.
So coming to the antioxidants in severe oligoasthenoteratozoospermia, we have a 2021 systematic review shows that the supplementation improves the sperm parameters, and also it provides the indications for antioxidant treatment in specific clinical conditions, including varicocele, unexplained and idiopathic male infertility as well. And the meta-analysis showed significant improvement in the sperm parameters for selenium, L-carnitine, acetyl L-carnitine, and CoQ for oligoasthenoteratozoospermia. Even in choosing the antioxidants, I think these antioxidants are giving a great benefit. So first IVF, 2021, there are no details available. 6 oocytes retrieved, 6 mature, and they had a total fertilization failure. It was an ICSI cycle, so there are no embryos. Couple were counseled for donor embryos in the same fresh cycle and transferred 2 donor embryos, and it was a biochemical. Also, they had a second cycle, which is a donor embryo, and it was a letrozole plus HRT. Endometrial thickness on the day was 7 mm, and 2 blastocysts transferred, it is failed. So looking at the history, male factor, 1 cycle, total fertilization failure, to a donor embryo in a same cycle, and again a donor embryo in a frozen embryo transfer. Anything are you suspecting?
Going for endometrial receptivity test. Better you go for endometrial receptivity. Assay.
Can also be.
Yes, ma'am. Hysteroscopy should be our first choice. And this lady on per vaginal examination, it was a 10-week uterus, irregular in shape. Scan showed 2 fibroids, which is one type 5 and type 3, and 2 small intramural fibroids of type 4. 3D scan had no indentation of cavity. Antral follicles were 6/7 and AMH was 1.8. Is myomectomy justified in this case? Sir.
Just previous slide. 2 fibroids, 4 into 3.5 in the fundal region. 3.7 the anterior wall. 1-2 centimeters in the posterior. Because in this lady, I prefer to do it because not only if it is you are attempting for the first time IVF, I wouldn't have advised. But it's a failed 3 IVF cycles. Definitely, I do advise. But I don't think I can remove all the things. You can leave out these 1 to 2 centimeters fibroids if away from the endometrium, But the bigger ones has to be removed.
So ASRM recommendations for myomectomy in asymptomatic women with cavity distorting myomas. Myomectomy may be considered to improve pregnancy rates. Myomectomy is generally not advised to improve pregnancy outcomes in asymptomatic infertile women with non-cavity distorting myomas. However, it may be reasonable in some circumstances, including but not limited to severe distortion of the pelvic architecture, complicating the access to the ovaries for oocyte retrieval. So this is another article which is giving information about intramural fibroids in close proximity to the cavity or that cause alterations in menstrual bleeding warrant removal prior IVF, and some authors recommend myomectomy only for cases like repeated IVF failure and which might cause an obstetrical complications or miscarriage in the pregnancy. So we have to choose the patient wisely and approach wisely. Do not open the cavity, obliterate the dead space. Best energy source is no energy source. And always have a look in the POD. Fibroids touching the cavity with history of recurrent pregnancy losses need to be removed. Male partner, he was diagnosed with azoospermia. That is the reason why three IUIs were donor. But in OSS, after evaluating he was a cryptozoospermia. So difference between azo and cryptozoospermia has to be clearly taken care of. And gonadotropins, and what is the role of gonadotropins? Let's discuss further. And also the evaluation of karyotype and Y chromosome deletion. Hypo cases, spermatogenesis can be induced with the gonadotropins. Karyotyping and Y chromosome microdeletions have to be advised for all the men less than 5 millions. And she had an antagonist protocol IVF cycle, and there were 8 oocytes retrieved, 7 of total fertilization and how to overcome it. Can we have just a brief discussion? So total fertilization failure accounts for 5 to 10% of IVF cycles, and following ICSI, oocytes still fail to fertilize almost 30% of the time, and it occurs in 2 to 3% of all ICSI cycles. Fertilization failure is mostly related to sperm abnormalities, where in ICSI, oocyte activation defects are the most frequent cause. Likelihood of recurrence in subsequent cycles is approximately 30, and fertilization and pregnancy rates appear to improve after assisted oocyte activation compared to conventional ICSI. So PGTA was also advised. Any of the panelists wants to have an opinion about pre-genetic testing in this particular case, if it is required or not required? Okay. So husband was advised TISA on the day of OPU. Whenever we are doing a testicular aspiration on the day of oocyte retrieval, what are the specific counseling we have to do? And what is the role of testicular biopsy, Dr. Shreya? What is the role of counseling a patient doing a TISA? What all precautions we have to take and what all the points to be included?
Here we have already found sperms in the ejaculate, 2 to 3 sperms. So most probably we would find sperms at TISA. So we would be telling him that we will be freezing it. But just in case they don't recover properly, we would have to do a repeat TISA at oocyte retrieval also. And yeah, of course, we have to keep the donor sperm option as a last, because if just in case the morphology is not right and the embryologist says no, then maybe you can also do a 50-50, like half the eggs with the, if they're, financially concerned, then, half the eggs can be, done with the husband's sperm and half with the donor sperm if they want, with their consent.
Yeah, testicular biopsy, I don't think it is advised anymore, because we can do it on the day of oocyte retrieval, and a trial TISA only if freezing of the sperm option is TISA sample is available should be considered. And she had a lap myomectomy and hysteroscopy done. All the fibroids were removed and she was suppressed with leupride. It was a downregulated HRT preparation done, and the endometrial thickness was 8.8 and beta HCG was 475. Myomectomy is not indicated for all patients. Azoospermia, read the semen report, check if the centrifugation is done or any spillage is there. This is a very commonest thing where the male will actually not tell. So our, the leading questions when we have an azoospermia report, it is always important to ask him how did he collect the sample, and also to always confirm the report again after 4 weeks. And the trial teaser with semen freezing backup only. Last case for today, 39-year-old lady with 41-year-old male, married for 12 years and she's hypothyroid. She had 2 ectopic pregnancies and 2 fallopian tubes were removed and 4 IVF cycles, total 8 embryo transfers in done. She conceived in 1 embryo transfer. It was a twin gestation. Unfortunately, she had aborted this in 5th month. Query cervical incompetence and history of twin ET and also fluid in cavity. She had a metroplasty, lateral metroplasty in 2011 and her AMH is 1.6. Husband is severe oligoasthenoteratozoospermia. What evaluation on male side for RAF? How to evaluate this recurrent implantation failure? Anyone wants to please take it up? Sri Lakshmi madam?
This patient, on ultrasound, we had seen fluid in the cavity. So,
Conceived twice, aborted.
Sir, she conceived in 2nd embryo transfer, total 8 embryo transfers. In 2nd, sir, she had twins. She, again, that was a miscarriage in 5th month. Could be cervical incompetence.
so could be cervical incompetence or maybe twins also, we don't know. But she had a thin endometrium and fluid in the cavity. So I would like to do hysteroscopy in her because she has undergone myomectomy also previous. This is the same patient. No, this is a different patient. This is an elderly lady. So I would like to do hysteroscopy in this case.
Here
Sir,
DFI we can do.
Huh?
Here DFI we can do, at least to counsel the patient that you've already undergone so much. So do you want to go ahead or not?
Okay, fine. Sir, should we put cervical stitch for every IVF conceived twin?
I would definitely put.
Anyone from the audience wants to please interact with us about this question? It was boring, I think, so I just want everyone to join us. Cervical stitch for every IVF pregnancy? Not necessarily. Singleton, not required. Twins? Twins, yes. Sir?
Check. Even in twin gestation also, I don't advise cervical stitch unless you have got the evidence to put it. Suppose if the cervix is good and the internal os is close, so sufficient length, more than 3 centimeters, there is no point in doing it because the pressure or the only presence of 2 fetuses doesn't initiate the. Yes, these people, they may go for premature labor. That is a total different issue. But you have to take all the precautions of preventing the preterm labor, not that in the 2nd trimester abortions. Suppose if they have got in the early 1st trimester of pregnancy, if the cervix is very short, I don't allow these babies to go up to 25 millimeters before I put a stitch. Because in the first instance, the first 8 weeks of scan, if the cervix is found to be 32 millimeters, at NT scan, it came up to 27, 28 millimeters. Probably there may be a suspicion. Then I'll put a fundal pressure. I'll see whether it is little gaping it or not.
I think cough impulse can also be done when we do an ultrasound examination.
Cough won't do it. You have to put a fundal pressure. Little bit of fundal pressure and see. If it is trying to burst it or just opening up, probably I'll take up this patient. This is my clinical experience. I don't know how.
So, but this case, she's 39-year-old with a 2nd trimester miscarriage. I think she needs a cerclage this time. And also RPL evaluation. Hysteroscopy was done, ma'am, for her. Additions were there in the cavity and all additions were released. We also instilled a hysteroscopic PRP into the uterus, and 6 months after we had a relook, and the additions, the patient was actually given a PRP installation and an IUCD also to prevent further. And hysteroscopy reveals the hidden stories, yes. Should it be done for everyone before IVF?
According to data, no, but here in Warangal, so much of PID, yes.
At least after one failed IUI, it's a must.
I think maybe first embryo transfer if the 3D endometrial cavity is good and there are no fibroids or polyps which are very clear. I think we can omit at least hysteroscopy because all the IVF rest is costly for them. So we can reserve one embryo transfer, and if that is failed, I think for the second one we need to do. So role of CD138, and if it is positive, how to treat, we are doing that because we have encountered many cases of chronic endometritis and the treatment is very effective for them. And she had a self cycle at the age of 39 years. It was a double stimulation antagonist protocol, and oocyte quality was very poor. TISA, testicular sperm, was used because the couple were very keen to use their own gametes. It was done, and 8 mature oocytes. There were only 2 embryos now, and she's 39. Dr. Shreya, do you want to counsel them for pre-genetic testing here, even at 39?
No.
Anyone
Because,
else?
see, it's just 2 embryos. Nature. Either it will become a pregnancy or it will not.
But
become
now
a
here
pregnancy.
2 embryos.
Even if we do a PGTA, we get to know it is a euploid. There is a 70% chance she's going to conceive, and there's a chance she might not conceive. Nature will decide.
No.
So why do we need to do a PGTA?
This is a case of second trimester miscarriage, and there are 2 embryos for us.
There are only 2 embryos. If we had at least 10, I could choose. There are only 2. So why would I waste her money?
So you
on,
want to
know,
put 1 embryo first, and if that has failed, the second embryo
depending
next.
on the grade of the embryo. Depending on the grade of the embryo. If it's like AA quality, then probably 1 and 1. But then I wouldn't waste her money because embryo transfer costs less, way less than PGTA. So let nature decide, because anyways 40, 42, the chance of, she should know that it is only 5% chance.
What if there are 4 embryos?
Even then, I would probably not waste her money.
Okay. Endometrial receptivity test, Madam Sri Lakshmi ma'am.
Recurrent implantation failure, I'll definitely suggest. I've not done many cases of this. So
Yeah, in
it
this
is
case, because it was total 8 embryo transfers and 1 was positive, I think endometrial receptivity test it can be suggested. But to our surprise, our P+5 on the day when the biopsy was done, it is receptive already. So with many previous failed cycles, it was decided for IRA, and 123 hours the patient had receptivity, and she finally was pregnant with 456 beta HCG. So TISA, I think we have discussed. PGTA we have discussed. AERO also we have discussed. I'm very much thankful to all my panelists who were bearing me from last 1 hour, and also for the audience. Thank you very much for your patient hearing. Thank you, everyone. Anyone has any questions, please, we can still continue. Any questions anyone wants to? The main thing was to cover all the points for the sake of audience and to give some message to everyone. I think that was fulfilled. And please join us for dinner. Thank you very much.
Thank you, Dr. Kavya, for inviting us. Thank you for the honor.
Thank you, Kavya, for having us.
Thank you, ma'am.
Request all the panelists to wait for a minute.
Just
I request everyone to join for a group picture, please. Yes, ma'am. Request everyone.
Also, we have a live band in the HSM hall. I request everybody to kindly stay back in the live band.
Very good. It's
Thank you, everyone. Kindly join us for dinner and there's a live band once again. I'm repeating, kindly enjoy yourselves. Thank you so much.